You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about orthostatic hypotension. We will talk about orthostatic hypotension, postural orthostatic tachycardia syndrome, non-pharmacologic measures that should be tried before ordering medications, and pharmacologic measures such as midodrine, fludrocortisone, droxidopa, and atomoxetine. So let's start with definitions. Orthostatic hypotension is defined as a systolic blood pressure drop of 20 millimeters of mercury or more, or a diastolic blood pressure drop of 10 millimeters of mercury or more within 3 minutes of standing up from a lying position or during a head-up tilt to 60 degrees on a tilt table. If the heart rate rises less than 15 beats per minute within 3 minutes of standing, it is likely neurogenic orthostatic hypotension, or NOH, often due to autonomic dysfunction such as Parkinson's disease, multiple system atrophy, or other causes. If the heart rate rise is more than 15 beats per minute within 3 minutes of standing, that suggests non-neurogenic orthostatic hypotension, which is most commonly due to volume depletion such as dehydration or blood loss or other non-autonomic causes. So that's an important branch point. Postural orthostatic tachycardia syndrome, or POTS, is a syndrome characterized by all three of 1. Frequent symptoms that occur with standing, such as lightheadedness, palpitations, tremulousness, generalized weakness, blurred vision, exercise intolerance, and fatigue. And 2. An increase in heart rate of at least 30 beats per minute during a positional change from supine to standing. And 3. Absence of, meaning the absence of a more than 20 millimeters of mercury reduction in systolic blood pressure with standing. Symptoms associated with POTS are those that occur with standing, such as lightheadedness and palpitations, those not associated with particular postures, such as bloating, nausea, diarrhea, abdominal pain, and those that are systemic, such as fatigue, sleep disturbance, or migraine headaches. The standing heart rate is often in excess of 120 beats per minute. Non-pharmacologic measures that should be tried before ordering medications include compression garments, fluid intake, bed positioning, dietary measures, physical activity, and avoiding heat exposure and other triggers. Compression garments, TED hose or compression stockings, will reduce venous pooling in legs and splanchnic circulation. Abdominal binders are useful to limit splanchnic pooling. This requires a prosthetics consult at some institutions. Fluid intake. You want to drink 2 to 3 liters of fluids daily or intravenous fluids if volume depletion is suspected. Drink 16 ounces of cold water 15 minutes before standing to increase intravascular volume. Bed positioning. Elevate the head of the bed. This helps reduce supine hypertension, which can cause nocturnal pressure diuresis and overnight volume depletion. For supine hypertension, keep the head of bed elevated at 30 to 45 degrees all times. Consider adding losartan 50 mg QAS for nighttime blood pressure control. Dietary measures. Increase salt intake. Add 2.3 to 4.6 grams of salt per day to help retain fluid and increase blood volume. Physical activity. Perform non-gravitational exercises such as stationary biking, rowing machines, or water activities to improve cardiovascular conditioning without orthostatic stress. Avoiding heat exposure. Avoiding high temperatures, such as hot showers or outdoor heat, can help avoid peripheral vasodilation and avoid orthostatic hypotension. To recap, let's hear from the 2017 AHA-ACC HRS guideline for the evaluation and management of patients with syncope about what recommendations are for non-pharmacologic management of orthostatic hypotension. Acute water ingestion is recommended in patients with syncope caused by neurogenic orthostatic hypotension for occasional temporary relief. That's a Class 1 recommendation. Physical counter-pressure maneuvers can be beneficial in patients with neurogenic orthostatic hypotension with syncope, Class 2A. Compression garments can be beneficial in patients with syncope and Class 2A. Encouraging increased salt and fluid intake may be reasonable in selected patients with neurogenic Class 2B. Now, let's move on from the non-pharmacologic measures to the pharmacologic measures. Fludrocortisone, or Florinef. The dose is starting at 0.1 milligrams once daily. You increase it by 0.1 milligrams the next week, and the maximum dose is 0.3 milligrams once daily. So there's not much leeway in going up for that dose. The mechanism of action of fludrocortisone is that it is a mineralocorticoid that increases blood volume by promoting sodium retention and water reabsorption. It also enhances the sensitivity of blood vessels to circulating catecholamines, improving vascular tone. Side effects of fludrocortisone include edema due to fluid retention. If seated or supine hypertension occurs, the dose may need to be reduced or discontinued. Fludrocortisone can cause hypokalemia, so check potassium levels before starting treatment and within 1 to 2 weeks of dose adjustments. Supplement potassium as needed. Next, midodrine. The dose of midodrine starts at 2.5 milligrams 3 times daily with meals. You can increase it by 2.5 milligram increments. The maximum dose of midodrine is 10 milligrams 3 times daily for a total of 30 milligrams per day, although some individuals go up to 40 milligrams per day. The mechanism of action is that midodrine is a peripheral selective alpha-1 agonist, leading to vasoconstriction of both arteries and veins, increasing blood pressure. Midodrine is contraindicated in patients with uncontrolled hypertension or urinary retention. Side effects of midodrine are supine hypertension. Avoid taking the drug within 4 hours of bedtime to minimize the risk. It can also cause pilomotor reactions, goosebumps, pruritus, gastrointestinal symptoms, and urinary retention. Midodrine does not cause anxiety, tremulousness, or tachycardia because it does not cross the blood-brain barrier. Next, we have droxidopa, or Northera. The dose starts at 100 milligrams 3 times daily. You can go up in 100 milligram increments as needed. The maximum dose is 600 milligrams 3 times daily. Droxidopa is a norepinephrine precursor that is converted to norepinephrine via decarboxylation. It can cause a blood-brain barrier. It's chemically similar to levodopa with an additional hydroxyl group. Side effects of droxidopa are supine hypertension, to a less degree than midodrine. Avoid taking this drug within 4 hours of bedtime to reduce the risk of supine hypertension. Then we have atomoxetine, or Statera. The dose of that is 10 milligrams or 18 milligrams once daily. It is a selective norepinephrine reuptake inhibitor, or SNRI. It increases norepinephrine levels by inhibiting its reuptake, which can improve vascular tone and blood pressure. Atomoxetine is contraindicated by glaucoma because it can increase intraocular pressure, and if you combine it with MAOIs, monoamine oxidase inhibitors, that can risk precipitating a hypertensive crisis. Side effects of atomoxetine are increased heart rate, blood pressure elevations, GI symptoms, nausea, dry mouth, and less commonly can cause urinary retention and sleep disturbances. If supine hypertension exists, then add nitroglycerin patch of 0.1 milligrams per hour overnight and wipe it off 1 hour prior to getting up in the morning. To recap, let's hear from the 2017 AHA-ACC HRS guideline for the evaluation and management of patients with syncope about what the recommendations are for pharmacologic management of orthostatic hypotension. Midodrine can be beneficial in patients with syncope due to neurogenic orthostatic hypotension. That's a Class 2A recommendation. Droxidopa can be beneficial in patients with syncope due to neurogenic orthostatic hypotension. Class 2A. Fludrocortisone can be beneficial in patients with syncope due to neurogenic orthostatic hypotension. Class 2A. Pyridostigmine may be beneficial in patients with syncope due to neurogenic orthostatic hypotension who are refractory to other treatments. Class 2B. Octreotide may be beneficial in patients with syncope and refractory recurrent postprandial or neurogenic orthostatic hypotension. Class 2B. That's all I have for you about orthostatic hypotension.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.